Welcome. This presentation is entitled Therapeutic Updates and Best Practices in the Treatment of Schizophrenia. My name is Dr. Troy Moore. I'm an assistant professor at the University of Texas Health Science Center, San Antonio, in the Department of Psychiatry, Division of Schizophrenia and Related Disorders. I'd first like to start off saying I have no relevant conflicts of interest to report in presenting this topic. Let's first start with the learning objectives. The first one is to describe the challenges associated with diagnosis of schizophrenia. Secondly, to apply existing diagnostic recommendations and criteria to practice in the management of schizophrenia. Thirdly, identify the treatment modalities currently available for the management of schizophrenia and apply them to patient cases using evidence-based medicine. Fourthly, evaluate a treatment plan for a specific patient based on the degree of schizophrenia to optimize safety and efficacy, suggesting modifications for treatment. And lastly, to describe the challenges associated with treating patients with schizophrenia. This first figure we'll go over really points home the complexity of the disorder of schizophrenia and everything that needs to fall in place for somebody to develop the disorder. First and foremost, patients have to have multiple susceptible alleles that each on their own have a small effect, but together they end up causing cellular changes. And these subtle cellular changes end up causing systematic changes, which causes abnormal information processing and ultimately leads to the symptoms that we know as schizophrenia in terms of temperament issues, psychiatric problems such as positive or negative symptoms, and also cognitive problems in terms of not being able to process information as rapidly or correctly as somebody without the disorder. Schizophrenia has about a 1% global prevalence. It's estimated in the United States that a lifetime prevalence of the disorder ranges from about 0.6% up to about 1.9%. Most commonly seen in late adolescence or early adulthood. Rarely does the disorder occur before adolescence or after the age of 40. There are some trends for the disorder occurring earlier in males and at a slightly higher prevalence ratio at 1.4 to 1. And the highest prevalence is seen in lower socioeconomic populations. And likely this is due to downward drift of these individuals not being able to complete school, to go to college, to keep jobs, and likely they end up relying on public assistance. Etiology of the disorder. Often what we've found is that there is a genetic connection to the disorder. As we see it in this graph, that identical twins have about a 48% concordance rates, likely due to higher susceptibility due to first-degree relatives. And this is also seen in a child of two individuals with schizophrenia. And as we see, it's much less in the general population, only about a 1% risk rate. So definitely looking at these as you get more genetic commonality with the individual with schizophrenia, the higher likelihood of developing this disorder. Genes implicated in schizophrenia are seen across all but 8 chromosomes. The most important being neuregulin 1, which affects NMDA, GABA, and acetylcholine receptors, dysbindin, which affects synaptic plasticity, catecholamine O-methyltransferase, which affects dopamine metabolism, G72, which regulates glutamatergic activity, and others that affect myelination and glial function. And we've also seen an increased paternal age, that more cell divisions in the sperm lead to potential more abnormalities in these genes. This picture shows where all these different genetic abnormalities can be seen, such as on chromosome 6, you see the dysbindin